live in 5,
4, 3,
2,
1.
All right, good morning, everybody. My name is Jens Chapman. Today is November 20th, 2024, and we're live from the beautiful Seattle Science Foundation venue. I want to thank Ben and Corey for putting everything together, and particular thanks to our visiting guest speaker, Dr. Stephen Lockey. He's an MD and MBA, and he's from UVA, and together with his colleague, Dr. Akhtan, he's going to talk about thoracic myelopathy and our STED talk, spine technology education, and the multidimensional discourse, debate, discovery, hopefully also, on a topic that is much overlooked and so pernicious if it is not diagnosed and managed correctly, thoracic myelopathy. Good morning, Dr. Lockey. Do we have an audio?
We do. Good to see you, Dr. Chapman. We can hear you.
Same here. I will give you a formal introduction for our audience when you start your lecture part, but Dr. Lockey and his partner are from the University of Virginia and in Charlottesville, and it's a fantastic place, one of the major centers in the US, and it's a real honor to have you with us. And again, thank you for choosing this topic. This is near and dear to our hearts and should be in any spine practitioner's mind at all times as we see our patients and so much focus on the low back or the neck, and that forgotten middle zone is so pernicious. As always, we'll have 4 quick cases, and we have our 4 wonderful clinical fellows who have each presented a case with a different angle. So I'll ask Dr. Nick Manasali from Rothman, so one of the places that you visited during your NAS fellowship, and he's going to present a case with a twist, and that's a more recent case, right, Nick?
Yes. Awesome, thank you. Awesome, thank you very much. And thank you for joining us, Dr. Lockey. I saw you had the recent cover of JOS with this topic, so congratulations on that. And looking
Thanks,
forward
Nick.
to
Good to see you, buddy.
Yeah, thank you. All right, so this patient is a uppers 70-year-old female who presented to our hospital with 3 days of mid-back pain and bilateral lower extremity numbness and some gait instability. So pretty rapid onset. For bowel and bladder, she had no issues. She was still ambulatory without assistance, but did have a subjective notice in her proprioception, gait, and whatnot. Past medical history, she did have a history of breast cancer. She had a lumpectomy in 2019 with adjuvant radiation and is still on anastrozole. She did not have chemoradiation at that time. She is a former smoker, but quit back in 1994. Social drinker, low BMI or reasonable BMI, and had a DEXA scan as part of her continued surveillance in 2022, and it was negative 2.4 T-score, so she is on calcium, vitamin D, and alendronate. On exam, she had full strength, but she did have sensation deficits, which seemed to be about T6 and below bilaterally, so just diminished sensation, as well as hyperreflexia in bilateral low extremities and 4 beats of clonus bilaterally. So we have an MRI with and without contrast here that including the entire neural axis, which I did not include here because this is the only concerning area, but basically there's this dorsal extradural mass with equal sac compression from T4 to T7 without frank cord compression or any abnormal signal or myelomalacia. And then the mass extended into the left paravertebral soft tissues in the same area between T4 and 8. A CT chest, abdomen, pelvis was done, which demonstrated a 6.4 by 7.6 mediastinal mass, likely concerning for, well, we'll see in a minute, I guess, but there was a central mass, not necessarily like a breast cancer or anything like that, not lung cancer either, that we could tell from this chest, abdomen, pelvis. So after, the staging.
Nick, can I ask you, and then I want to take that question to Dr. Lockey. What led to this thoracic MRI? Was there anything in the physical exam or in her history that tipped you all off to get this study?
Yeah, I think she had no cervical issues, no upper extremity issues, rapid onset, and really mid-back pain And again, the sensation deficit also seemed to be coming from the mid-back. So
So there's a thoracic sensory level then?
yes, yeah, around T6. So
Did you see her? Did you have long tract signs outside of hyperreflexia?
4 beats of clonus, so not technically, no.
And one more time, so she had a past malignancy history with breast
Yes,
cancer.
breast cancer.
How many years ago was that?
That was 2022. She had a lumpectomy, adjuvant, anastrozole therapy, no chemotherapy, but she had negative lymph nodes at that time as well.
So Dr. Lockey, this is in a way a lucky patient, but also maybe just par for the course. I mean, somehow somebody thought to get a thoracic MRI scan on her. Is there a protocol at UVA for longer-term survivors of malignancies? And if so, when should that be applied? How should that be put into action?
In terms of screening for thoracic stenosis?
Yeah.
No, we don't have a protocol in place, but I think the important point was raised in the exam, which is that there were some clinical findings, for example, the low extremity sensory deficits, some pathologic reflexes with the clonus that I think were important to lead to the advanced imaging. And then you pointed out an important point, Nick, which is that mid back pain often will point us to the source of pathology. But the key is the clinical suspicion, particularly in these patients with a history of malignancy, that we have to always keep the thoracic spine in mind. And if there's any clinical suspicion, order the advanced study.
And again, that thoracic sensory level in conjunction with the hyperreflexia is probably the key kind of a pointer. Was she ambulatory? Was she?
She was, yeah. I believe Dr. Gold saw her in consult, but she was ambulatory. She's, for all intents and purposes, a healthy patient, lives
So
alone.
no falls, bowel bladder control?
No issues with bowel and bladder, no falls, but very kind of sudden onset of this sensory deficit within about 3 to 5 days prior. So kind of she sought care immediately.
So now let's take us to real time. So this patient, I'll just make the time frame up, arrives in the usual time at around 8 p.m. Okay, after having been in the ER and somewhere in the region for the last 5 hours, this thoracic spine MRI is then obtained, and voila, we have a problem.
Yeah.
So walk us through the timeline of how fast does everything happen, or should everything happen? What are the first measures that you get then?
So we kind of discussed it, but after physical exam and finding the findings we did, I would always recommend a neural axis MRI if you have concern. Again, for malignancy, for concern. In this case, she had thoracic pain, but you can't always rule out that there's not cervical issues. So a full neural axis MRI, and then upon finding that, we then obtain a CT chest, abdomen, pelvis for kind of screening to find the primary malignancy, which we likely did with this mediastinal mass. And then thereafter, for this particular patient, I think it was 1 day in the hospital, pre-op optimization, again, the screening tests, and then on hospital day 2, we performed the intervention.
So hospital day 2. So this is an important thing. So first of all, diagnostically, you may talk about this, Dr. Lockey, but is it necessary to get a contrasted neural axis MRI? How important is that? We always get asked that, and again, frequently we don't have a full handle. Frequently we don't have a full handle on the patient's physiology and health. How important is it to have a contrasted MRI for a neural axis screen?
From my standpoint, when I think about getting a contrast study, recurrent disc herniation, infection, malignancy, I tend to always get it. But in a patient like this, who, like you astutely pointed out, it's often all too frequent, where they'll be sitting in an outside ED, they'll have 2-week history, 3-week history of progressive symptoms. There's this delay in transfer. Ultimately, they arrive here, and you have what you have. And then you have to make a decision. What's the neurologic status of the patient, and where are they headed? Are they stable? And is this something that we can do further workup on, or do we need to make a decision based on the data that we have? In this particular case, we have a mediastinal mass. There's obviously a large dorsal canal component here. I think as long as I had a tissue diagnosis, I'd be very comfortable at this stage taking the patient for surgery.
Now, that was the next question. So this is the one malignancy we have here. How important is it to have a biopsy before we do something, or is cord compression a primary concern here? This is, again, a difficult perfusion area. This is near the watershed area of the cord supply. You'll probably talk about that. So how important is it to have a biopsy before we intervene, or is it sometimes just relevant to get an excisional biopsy and decompress the cord?
I tend to like to have tissue. It's just my personal bias. Having more information is helpful because from my standpoint, if you get in there and get into a bleeding situation when you could have preoperatively embolized, I mean, you could run into trouble pretty quickly. This is a patient who's, just in the history, without looking at any imaging, you could pick up very quickly that she's frail, right? And how much physiologic stress can she sustain? So I would do everything I can to get her optimized, but that doesn't mean that we don't watch her very closely neurologically. The first sign of trouble, just make that decision to go to the operating room. Obviously, agree with the concern about the watershed area here. This is a very tenuous area of the thoracic cord, and we have to watch her closely.
So so after spending the night in transfer from some ER to some hospital, which might have been ours, what happened next? How long until the delay was, were steroids given?
I think low-dose steroids were given. She's non-diabetic, but not necessarily like the NASCAS-2 protocol or anything like that. So low dose, I think it was 6 milligrams Q6 or so.
And what about the biopsy thought?
Yeah, so I agree with Dr. Lockey. It's always, especially on my own, I would probably try and always get tissue diagnosis. I think here, it's been my experience that we often are comfortable enough to move forward and have the resources and the anesthesia and whatnot to move forward and obtain an intra-op tissue diagnosis. So that's what we did. We performed a posterior T4 to T8 laminectomy and extradural mass removal. It was kind of this bluish, friable mass. Again, it was completely extradural. It was not super adherent to the dura. And just laminectomy alone. And what I thought was interesting about this case is post-operatively, by day 2, she had a significant improvement in the sensation, mild improvement in her proprioception as far as, deep vibration sense as well improved. And she actually went home by day 3. Unfortunately, the pathology came back about a week later with metastatic, poorly differentiated squamous cell carcinoma, so possibly thymus or lung based on the prior CT chest, abdomen, pelvis.
So, Dr. Lockey, again, we don't want to get into too much oncology debates here, but this is something we've seen more and more. I have no idea about the statistics, but patients have had a previous primary neoplastic disease come back years later with a different oncologic disease. Is this something that's on your radar? Is this something that you have any statistics on?
We are seeing the same thing. I think patients now are living longer and the durability of some of these treatments with the neoadjuvant therapy with some of these primary cancers. But we're seeing, there's two sort of considerations. One, is there a genetic component where people are predisposed to neoplastic disease? And are we seeing the secondary manifestations of the longevity associated with the initial treatment? Or are we seeing the sequelae of that therapy? But I think as we get better and better at cancer therapy and people are living longer, we're going to see more of this.
The other question about the biopsy is the following. So I totally agree, and this is what we preach, but we don't act on that necessarily. Biopsies nowadays mean that we're waiting for protein markers like mutations, the CD117 marker, for instance. And in our facility, in our neck of the woods, so to say, they take a while to get back. And 5 to 7 days is not unusual and can be longer in certain cases. So this is one of those cases where we see a protein marker having a greater proclivity towards a diagnostic hint than the actual primary tumor site origin. So this is one of the worries that I have is when we have a biopsy, we live in this thought that there's a diagnosis within hours later, maybe even on fresh frozen, and the reality is not so fast, at least for us. How does timing of getting a meaningful, actionable result matter for you?
I think that it matters in terms of how it's going to dictate the timing for surgery and what interventions to do preoperatively. So I really want to know, is it thyroid, is it breast, or is it renal cell? It's sort of, if it's those 3, I tend to be more aggressive with having something embolized, or at least talking to our interventional radiology folks to see if it's feasible. Just because I don't want to get into something where we have a lot of bleeding and figure that out later. Other than that, I think from the timing of surgery, particularly in the thoracic spine, tend to be more aggressive with going earlier just because of the tenuous nature of the blood supply and the risk of neurologic decline without intervening.
It's a great answer. And something that'll come back for the three other cases, and we'll switch then in a second, instrumentation. So I think the attending in question just resected the mass.
Yeah, no instrumentation.
Didn't do a laminoplasty, didn't do a unilateral laminectomy, it's a full laminectomy.
Full laminectomy, yeah.
So what are your thoughts on instrumenting when you've kind of decompressed the thoracic canal?
I tend to always instrument after I decompress the thoracic spine for two reasons. One is that I like to be very lateral to have full control of the lesion. And if you go lateral, you're obviously compromising the segment stability. But two, I don't think you lose much by instrumenting the thoracic spine. You know, as long as you do safe instrumentation, it's a rigid segment. You can prevent some of the sequelae of not instrumenting and resulting in post-laminectomy kyphosis. So I just have a low threshold to instrument, as you'll see, you know, in some of the cases that we're going to show.
Great. We must switch. We have Dr. Mark Kramer here. Thank you, Dr. Minasali. Dr. Mark Kramer is from Madison, Wisconsin, neurosurgical colleague, and he, like Dr. Gold, are lucky to have him here today. They're both coveted around the nation. They're traveling for the interviews. If somebody wants them, you got to act fast. So Mark's been terrific, as have all four fellows been, and this is, again, a little bit of different slant on thoracic diseases.
Thank you. Yeah, so I'll present this patient. This is a younger gentleman. He's only 30 years old. He ultimately had cauda equina syndrome, a true cauda equina syndrome, about 18 months prior to the presentation we'll talk about today. But he had a 5-1 disc herniation, classic bowel bladder dysfunction, and some leg weakness, and he had a laminectomy and discectomy at the time with nearly complete bowel and bladder function recovery, which is great. He did have some mild residual left leg weakness. Coming up again about a year and a half after his surgery, he began developing some like progressive leg weakness and just unsteadiness on his feet. He had been initially working with physical therapy outpatient, and then all of this kind of came to a head when he was at his therapy appointment and had a fall, and he felt like his weakness became much more severe. His only pertinent past medical history is obesity. Here's his exam when he initially arrived. You can see his BMI is 40. He did have an elevated PVR, and a Foley catheter was placed at the referring hospital. And if you look at his strength scores here, bilaterally, he's quite weak in the legs. Not even anti-gravity on that right side of the hip. He didn't have any clonus. However, he did have quadriceps pathologic reflexes, and he did have very brisk patellar reflexes and slightly diminished sensation throughout both legs. So here's his scan.
And how, yeah, go through the discussion of the scan, but I'll ask the same question. How long did it take from the initial presentation of a lack of ambulatory function to getting a thoracic MRI? Was that a pretty linear, rapid sequence, or was that delayed?
If you talk to the patient, almost a year of leg weakness, but it was really that acute episode of pain that, more so pain in his back and also into his lower back when he fell. And I don't know the details around the fall, but that's, yeah.
Okay. All right. Now, show us what you have here on the thoracic spine.
Yeah, so for brevity's sake, I did not include a cervical or lumbar, which were also performed, but the pertinent positives are here. So you can see he's got real severe stenosis at T8-9 and also T9-10. And I can show you on these axials as well through both those levels. So here is 8-9 right here. So it's playing here. There's 8-9. You can see effacement of the CSF signaler on the cord. And then at 9-10, very similarly, suggestive some arthropathy and severe stenosis at this level as well. From the MRI, you can't really tell whether or not these disc herniations are calcified. So we did get CTs, a CT of the thoracic spine as well. And I show an axial cut through both these levels. So this is the CT, an axial cut through T8-9. This is the MRI correlate here. And then I should also note that on the MRI at both these levels, at T8-9 and more so at T9-10, there was some T2 cord signal change. And here's T9-10. So in summary, 30-year-old gentleman, he has pretty severe stenosis at 2 levels in the thoracic spine, combination of calcified disc, as you can see from the CTs previously, and some arthropathy. He's got T2 cord signal changes and clinical signs of myelopathy.
So great case, typical case. So we have a lot of patients here with morbid obesity and gait complexities, impairment are not that uncommon. Identifying real pathology from just disability, from body weight and mismatch with muscle function is not straightforward necessarily. Any thoughts on when and how to trigger a myelopathy workup, Dr. Lockey? How do we assess and differentiate in these larger patients meaningful concerning neurologic exams, and when do we activate the neuroimaging modalities?
So this is a great case, Mark, and a really good learning point, because you have a patient who you didn't show the lumbar MRI, but based on the history, young guy, cauda equina syndrome, morbidly obese. I can guess, and you correct me if I'm wrong, but I bet that in his lumbar MRI he's got a congenitally narrow canal, and I think you have a patient, acute cauda equina syndrome gets better right after surgery, and then all of a sudden presents with progressive weakness. Immediately, that for me triggers a workup. I mean, I think, Steve Ludwig trained me and really hammered this home. People present with, foot drop or gastroc weakness. Typically, you're thinking lower lumbar spine, and that can be explained by stenosis. But proximal muscle weakness, I mean, you really have to have a low threshold to image the thoracic signs, particularly if they don't have any upper extremity findings. So for me, a patient that gets worse after, a period of improvement in acute cauda equina syndrome. And the other thing that's interesting, and we're seeing this too, are patients who are young, males, morbidly obese, tend to have a congenitally narrow canal. There's this propensity to develop heterotopic bone. So that CT scan demonstrated ossification of ligamentum flavum, I think at 10-11, right? And at 9-10, a calcified disc. This is obviously very challenging, but I think the key for me is that change in neurologic status after a period of improvement would trigger a more thorough exam and looking for those hyperreflexic findings, which you reported, and then I would look proximally for the central nervous system stenosis.
So here we have an extra imaging modality, a CT scan. Tell us why this is necessary and what you gleaned from that, Dr. Kramer.
Yeah, so CT in these cases, I think, is absolutely necessary. For soft disc herniations, it totally changes your approach to these types of things. In fact, in the era of endoscopy, a lot of people are actually doing endoscopic discectomies in the thoracic spine. And if it's a calcified disc like this, it just essentially, from my perspective, rules out the use of an endoscope. It just makes it too challenging. So the CT is extremely helpful to identify calcified discs, and it changes your approach.
So important. Would you agree with that, Dr. Lockey? So CT is kind of almost the norm now before you start intervening in the thoracic spine for a disc or stenosis condition?
100%. I kind of hit that point home a couple of times in the talk. I mean, I think it really is standard because you have to understand if there's calcifications, there's a propensity for dural adhesions, intradural extension. These calcified discs are very dangerous. And you pointed out, very astutely, Mark, people are doing this endoscopically. It's a great technique. It's far less morbid than more traditional techniques. The problem is you have to get ventral. You have to get ventral, create a cavity, and tamp all of that material away to safely do the operation. You're never going to know the correct approach unless you get a CT scan. Some people even will advocate for a CT myelogram to better discern if there's any intradural component.
All right, take us forward, Dr. Kramer. So we have a critical cord compression again. We have cord signal changes. There's a calcific element to this. This is a morbid patient. This is a physiologically burdened individual with body size concerns, prone position, not well tolerated frequently, hypertension, poor airway excursion. How do you proceed here? How much do you do?
Once we got this consult, we brought the patient over urgently for surgery. We got the CT scan, as I showed, and we made the decision to, of course, decompress the spinal cord. At T8-9, it was a transpedicular approach and actually a partial corpectomy at T8-9 to actually get that calcified disc and decompress the cord at that level. And then at the level below, we did a wide laminectomy, and we're able to kind of take down that calcified ligamentum flavum and decompress the cord posteriorly and laterally for a nice decompression. And here's the postoperative CT at T8-9. You can see that there's a nice defect, and as Dr. Lockey mentioned, key things being creating a void anteriorly to push the calcified disc and work anterior to the cord, which was done at this level. And then at T9-10, most of that compression appeared to be from kind of essentially posterior elements and some calcification that longitudinal ligament, which was taken down posteriorly.
So I like that you have a post-op CT, and again, I consider these thoracic myelopathy patients a incomplete cord injury, unless they're complete, but a cord injury for that matter. And as in trauma care, we want to get a post-operative CT scan, yet that does not seem to be widespread. I see a lot of people who've had previous thoracic cord level surgery, and we get a CT and there's not a lot that has changed, especially ventrally. Dr. Lockey, is it norm for you to get a CT scan after a cord level surgery? And how do you rate, for instance, that one area where there's still some mass effect on the cord, that left-sided kind of a booger?
I do like postoperative imaging for thoracic stenosis, simply because I think, you have to make sure, particularly in this case, that you got rid of the ventral source of compression. I mean, the thoracic cord does not flow back, and so it can be hard intraoperatively to really discern the degree of decompression. So I think a post-op CT is a great idea. I think you guys did a great job. I mean, I was leaning to being a little bit more aggressive than a transpedicular approach for that calcified disc, just because it is so challenging to get ventral. But it looks like you did a really nice job. There is a little remnant of that disc. It can be hard to get ventral enough and to the contralateral side to see that and get control. But really, really well done.
How did the patient do clinically?
Yeah, so post-op patient actually did very well. Patient remained quite weak during his inpatient postoperative stay, which was not too surprising. However, he was able to ambulate again on his own prior to discharge to the rehab facility. He had a 5-day stay at a rehab facility, and we just recently saw him at 3 months, and he's actually nearly back to full strength. His exam here is at the 3-month mark. You can just see he's got very mild left ankle plantar flexion weakness.
How's bowel and bladder control? That was kind of impaired or borderline impaired in the beginning. Does he have a spastic bladder? What's going on there?
He's no longer doing any straight cath. Has no Foley, obviously. He's actually voiding pretty well on his own. Doesn't sound like it's 100% back to normal though.
Okay, but so ambulatory, he was like an Asia C prior to surgery, and I'll ask Dr. Lockey to comment on grading. I don't want to preempt this talk. Is he an Asia D now? Is he using ambulatory aids, or is he independently ambulatory?
Ambulatory aids.
Yeah, so an Asia D, so he went up 1 grade.
Yep.
Okay, good. And no spasticity anymore?
I don't believe he's all that spastic. I think there's still some element of some kind of pathologic reflexes in his legs. But he's actually walking around actually pretty well.
Good. All right. Thank you, Dr. Kramer. And if anybody wants to hire him, get in line. He's going to run off for another job interview shortly. Thanks, Mark. We'll go for Dr. Colin Goldyet, who will have a variant of the same theme. And a shout out to our colleagues from Pakistan, Dr. Amir Aziz and Dr. Tariq Sohail. They'll have their sagittal balance symposium from the Pakistan Spine Surgery Society this weekend, and I'm honored to be one of their faculty online together with Dr. Shafri and Dr. Rue. Great honor. Look forward to seeing you virtually. Dr. Gold.
Morning. So here is a case of a 50-year-old man with a history of severe morbid obesity, BMI around 50, who presents with progressive bilateral lower extremity weakness after a mechanical fall about a week ago. The patient had some prior back pain and had been seen by a spine surgeon previously with no intervention. However, he acutely worsened after this fall. He was admitted to an outside hospital and had another fall while an inpatient, after which his condition drastically worsened. Imaging was obtained and he was transferred to Swedish. So the patient was mobile with a walker prior to admission, but could no longer ambulate after this other fall, or second fall at the outside hospital. The patient also reported diminished sensation below the nipple line. He had stool incontinence, a PVR was obtained, which was 600, and he had bilateral lower extremity spasms that had worsened after these falls. This is his neurologic exam. His uppers are intact in terms of sensory and motor. On the lower extremities, he has distal more so than proximal weakness bilaterally, a sensory level of incomplete T4. Reflexes were 0 in the lower extremities and 2 in the bilateral uppers. I didn't write this there, but he also had positive Babinski bilaterally, and then Asia C at T4 level. And this is the patient's MRI.
So this time we're talking about the upper thoracic spine and a patient who had pretty acutely deteriorated. This is, again, it's a recurrent theme, a clearly missed injury, very large male who had fallen. And again, falls happen, but the nature and the details of the fall were never fully investigated.
And then we also have a CT.
So these are severely ossified discs, almost like a OPLL condition, maybe perhaps an OPLL condition of the thoracic spine, congenitally tight canal, hyperostotic bone morphology, so the osteology is clearly pathologic, and a very acute core deterioration. So he probably was a undiagnosed Asia D beforehand. And tell us again about the acute deterioration and what happened at immediate fall and deterioration phase.
Yeah, so it's unclear what his neuro exam was within a month of this. He was neurologically intact when he had seen an actual surgeon like 3 months prior, and then had a more acute deterioration over about a week with these 2 falls, and then severely kind of fell off the cliff after the second fall at the outside hospital.
So this is, again, just, I remember this patient because this is one of these last 2 cases are mine. So I take responsibility for the defeats or the questionable choices, but it's a very unforgiving task. I mean, this patient clearly showed warning signs that there's something wrong. In retrospect, we're always smarter, but there's nothing done. And then suddenly the patient comes in and there's a severe neurologic deterioration. So again, Dr. Lockey, what are your thoughts in Charlottesville in terms of how acute do you want to intervene? This patient clearly suddenly lost the critical remnants of ambulatory function overnight and now has a very complex calcific disc pattern. This is a morbidly obese patient. So again, turning him prone is going to change he's going to get pulmonary hypertension, however you position or try to position him. Maintaining high MAPs, which you'll undoubtedly talk about later, is going to be a real challenge. Having good oxygenation alone is going to be challenging. What are your thoughts in terms of acute intervention? How radical do you want to be here?
So, Dr. Chapman, I'll tell you, I think it's really important point you made, which is that this is a spinal cord injury, and I think it really points to the fact that you have these spondylotic changes, these calcified discs, there's underlying stenosis, and then really low energy trauma, right? From a fall from a patient who's myelopathic, has gait instability. A fall can result in severe neurologic sequelae, and that's one of the key points of maintaining high suspicion early and making a diagnosis before something like this happens. But because as you point out, this is a cord injury. I think a young patient, I would try to take this within 24 hours. Obviously, a very challenging problem given his body habitus and the degree of stenosis. The fact that these are calcified and upper thoracic are very concerning. I don't, in terms of how aggressive we'd want to be, just doing a laminectomy for these large sort of central calcified areas of stenosis. The data on that and the results, which we'll talk about, are just not good. I think you have to go after the lesion, and whether you get very aggressive and try to go ventral, or you do a transpedicular approach like you did in your previous cases, I think is dealer's choice. But I think you have to address the area of stenosis, particularly in this region of kyphosis.
All right, Colin, take us forwards.
All right, so we ended up doing a C3 to T6 laminectomy, C2 to T7 posterior fusion, and then Dr. Gottlieb with plastic surgery helped with closure for myofascial advancement, flap that was with plastic surgery. Here's a post-op CT. So this is the cervical spine.
So complicating matters, and I didn't want to over-technicalize it, but the patient had pretty severe OPLL in his cervical spine also, and while the neurologic insult clearly came from the upper thoracic spine, I wanted to have a clear possibility for the cord to fall away posteriorly. And this is where, I'll tell you, I chickened out. I did not feel comfortable diving for those discs and doing a costa transectomy. We were just physiologically happy to have this patient go through the surgery safely, because it was a pretty significant challenge to position this patient alone. I forgot what the BMI was, but it was in the...
Over 50.
It was over 50, yeah. So around 50, positioning prone in our frames starts becoming a real challenge. And I think we even use supplemental chairs under the frame to support it, like what Dr. France taught us. And imaging intraoperatively becomes almost impossible. So thoughts, and we'll then tell you how the patient did neurologically. I did not dive for the anterior disc, but I did an extensive decompression above and below to let the cord hopefully fall back. And I gave him best possible straightening instrumentation.
I think you did the right thing here. The OPLL in the cervical spine is obviously very concerning, and the fact that you needed to extend up. I think doing a Y laminectomy, went all the way up to C3, give the cord the best chance to float back. This particular patient, which I think, it's also to do that costa transversectomy and get ventral, you need visualization, you need fluoroscopy, and visualization, particularly in this case, is really tough. So I think for the acute phase, you did the right thing and what I would have done.
I want to give a shout out to our plastic surgeon. If you look at that post-operative CT scan and the neck fold in the back, you can only imagine how many layers of scarpous fascia we went through. But that the patient did not have an infection speaks for the quality of that soft tissue management. So thank you, Dr. Gottlieb. How do you do neurologically? The big question now. I chickened out. I did not do a costa transectomy, did not go for the ventral decompression.
Yeah, so he's given our high-dose solumedrol spinal cord injury protocol before surgery, and then continuing for, actually, I think he had 2 days after. Discharge exam was not fantastic. He had no voluntary movement in the bilateral lower extremities, diminished sensation below T6, and a chronic indwelling foley at the time. Was discharged to acute rehab. However, when he returned to clinic 6 months later, this was the last neuro exam we had, he had significant improvement of strength in the lowers. So fours distally where he was 0 before, and then the proximal muscles had improved even slightly as well.
So he went from a Asia C, basically there was just a trace motor, to an Asia D. He could mobilize, he can transfer. He lives independently, remarkably, at his size, but he clearly is not an Asia E. I mean, so he uses heavy ambulatory aids, and he literally is mainly transfer household kind of ambulation, but not independent gait. And this is like 2 years out now. I think you just saw him not too long ago. So any thoughts? Should we re-intervene him? He's, by the way, we tell all these patients, we try to facilitate weight loss programs. We have a very good one here at Swedish. It literally never happens. Financial restrictions apply. A lot of these patients are not insured optimally. There are obstacles towards effective weight reduction. So the hope, the wish to get effective weight reduction remains elusive, I should say. So any thoughts on re-imaging the patient now? We've had a period of recovery, there's improvement. Should we look for further anterior cord decompression opportunities?
No, I think this is a win, Dr. Chapman. I think the fact that he's improved a full Asia grade, living independently, I think the gains from this point are improvement in body habitus and overall physiologic health. I don't think that going back in and addressing those calcified discs is something I would do at this stage. I think great outcome
The
overall.
last case, again, the really key thing for me was that I remember very vividly, we had a very busy weekend OR schedule. We are full house, and this patient somehow appeared in the morning. He was admitted to a hospitalist service because he couldn't walk anymore. And we were literally on Saturday morning rounds when somebody said, hey, this man can't walk anymore. And we walked into the room, and again, a whole new problem emerged. And again, given the timeline, we actually changed everything around, but got this patient to the OR within a couple of hours. But I don't know whether that was unnecessary drama or not, but we tried our best to get this patient remodeled. But I see this a lot, that these acute cord decompensations happen at vulnerable hours where you, the system, everybody is at their weakest, and it's never perfectly plannable. So that was a very big push there, and we tried our best, but I, again, still reflect on, should I have done a corpectomy or not? To get those discs out. Final case, and there we'll talk. Thank you, Colin, great presentation. And Colin, talking about acute, we have an acute cord. Can you check on the patient? We're going to go to the OR first case start. Can you make sure that everything is signed and everything? Yeah. You know what I'm talking about, C2 to T2. Thank you. We have an acute myelopathy patient downstairs. Dr. Cameron Hawks from the Dallas-Fort Worth area, near and dear to my heart, and he's going to talk a little bit more about technique. And there's yet again a recurrent theme that he'll undoubtedly address in this particular patient. So Dr. Cameron Hogshead.
Before you start, Dr. Hogshead, if it's okay, Dr. Chapman, I'm going to have our clinical fellow, our outstanding clinical fellow, Dr. Akhtar, to chime in on this last case, okay?
Absolutely. Thank you. Sorry I didn't acknowledge you earlier.
No problem.
Good morning, all. Thank you. We have a case here of a 40-year-old female who presented with progressive falls and bilateral lower extremity reported weakness and pain. This was a spontaneous onset about 2 to 2.5 months ago with a rapid progression of left greater than right lower extremity weakness, particularly when trying to transition from sitting to standing and any ambulation at all. She had no upper extremity symptoms reported. She was a previously fit independent ambulator, no assistance, and she had graduated herself to getting a scooter to help her mobilize around. She did report signs of a intermittent urge incontinence, especially when, again, transitioning from sitting to standing. She would lose urine, kind of questionable for spastic bladder, and she did have a past medical history of high blood pressure. Not noted in here, she does have a BMI of 35. And so morbidly obese here in Seattle. For us in Texas, that'd be slightly above average. Her past surgical history was L4-5 fusion she had for low back pain with radiculopathy in 2013 that she recovered well from. And her social history was unremarkable. She is a social worker and a previously active patient. And then you can see on the MRI there, just a snapshot of a thoracic disc with associated cord signal changes. Her ASURE score, isolated strength, was unremarkable when lying, but she did have long track signs, hyperreflexia, as well as clonus, and she did have basically some reported disc Romberg, unable to stand, basically with the eyes closed and some wobbling gait, and put her at a Nurek 4. This is a 2T sagittal and axial cuts at the T11, T12 disc space there. You can see she has severe degenerative changes and facet hypertrophy, as well as disc herniation causing myomalacia of the spinal cord there at that level.
So the recurrent, yeah, go ahead.
CT scan was obtained as well, and you can also see her previous L4-5 fusion. Here's remarkable. And then at the very top of the CT scan, the sagittal there, you can see the disc herniation, just some slight stippling, but no real significant appreciable calcification, mostly concerning for soft disc herniation.
So here we have a classic picture, again, of a delayed diagnosis. This is a medical professional who works with spinal cord injury patients all the time, and the patient is myelopathic, running around with a scooter, when somebody somewhere finally, like weeks later, decided to get a lumbar MRI that then at the border showed that there was something not quite right. So this is, I'm sure, not the only place in the world where we have this problem of where we focused on the lumbar spine. The patient had a previous lumbar surgery done elsewhere. But the patient herself was woefully unaware that there was a significant gait impairment. And this is a partially calcific. If you can take that axial cut down a little bit more, partially calcific, significant disc herniation. And this patient literally uses one of those scooters, those leg scooters, to get around now, but is a absolutely wonderful person. So thoughts on, again, acuity of intervention and how do we do this now? Here we have a single level disc herniation. There are no major physiologic impediments, partly calcific disc herniation. Our colleagues at UVA.
Thank you, Dr. Chapman. I agree. I think spinal cord injury still, but given the fact that she has preserved strength, she's still somewhat ambulatory. It's not so much of an emergency, but more of an urgency. I would still like to get to it sooner rather than later. And I think with the mostly soft component of this disc, I would tend towards a posterior only procedure. She does have some segmental kyphosis right at that level. And I think doing a posterior decompression, I'd be worried about progressive post-laminectomy kyphosis for her. So I think I would back it up with an instrumented fusion as well.
So Dr. Lockey mentioned it earlier, and so did Dr. Kramer, endoscopy. You're a young gun, you're undoubtedly super talented, way more than I am. Is this a case that you'd venture out in endoscopy? I know we have Dr. Yanamura in our audience, who's a wonderful minimally invasive surgeon. So endoscopy?
Personally, we don't do a lot of endoscopy here at UVA.
We do open anatomic technique here at UVA, Dr. Chapman. So.
All right, so I don't feel too anachronistic. All right, take us forward, Dr. Hogshead. So I think we concur. And so how do we do it, and what do we do here to get an optimal decompression?
Yeah, so this was a all posterior approach, and we did a transfacetal approach with bilateral discectomies to really clean out that disc, and then a instrumented fusion and neutralizing the spine with hardware after sacrificing both facets to get around the cord, get great visualization, make sure the disc was fully taken and no further impingement of the spinal cord there, and then a banana P cage there. And you can see we corrected the kyphosis there, neutralized the spine, prevented the spinal cord from draping over anterior or any chance of anterior compression there. We initiated the NASA's steroid protocol as well, kept that for 24 hours, and then had MAPS at 85. During our decompression, motors and SSPs stable throughout the case, and then we elected to go 2 up and 2 down from where we did our disc work. Some other intraoperative techniques we use. This is a sinus endoscope visualization from both sides of the spinal cord. And you can see the probe coming from the other side of the spinal cord, coming easily passing just ventral to the spinal cord where the disc would be after the disc was removed, indicating to us that we did a thorough decompression. And then we did also use intraoperative ultrasound, which was my first time using and was actually very nice, very helpful at the end of the case as well. These are pictures not from our case. We weren't able to save them, but pretty similar to kind of what we see. Basically, you can see a disc herniation there at the green intervertebral space there and the cord draped over it. And then afterwards with sagittal and axial cuts of the ultrasound, you can kind of see basically a continuity of the shape of the cord and see if there's any residual deformity or effacement of the cord afterwards. And for us, it was completely contiguous throughout, which was very reassuring to see. This is a postoperative CT scan. And you can also just confirming satisfactory hardware placement and alignment, as well as decompression as planned.
So first of all, technique, and then I want to address some questions in the chat room by Dr. Bhargava and Dr. Qureshi, who I thank for their contributions. So we did a classic open technique. We did a bifacetal approach. We developed a good plane of the dural sac and then did ventral disimpaction after creating a cavity on both sides. And we used a 70-degree sinus endoscope for a dry scope. I apologize for the bad picture quality, but our scope chart did not allow a direct download that day. And we used that new BK ultrasound to basically make sure that we had a clean cord with a full laminectomy there. So, and arguable, again, we went 2 levels down just because she's a little bit larger, and that leaves her 3 discs to her L4-5 fusion. Is that overkill? Your thoughts?
No, I think that looks great. You corrected her deformity and got a good stable construct with a great decompression. My question for you, I wanted to ask from a technical standpoint, when you do these thoracic T-lifts, do you take the nerve root? Do you rotate the cord at all, or you just get as lateral as you can?
This is like a mini costa transectomy. Basically, the roots, you were there. The roots are nowhere close to that, actually. You're right below the roots. And depends on how much body you take off, but we just do more or less an expanded intradiscal osteotomy. We published that, I think, years ago in Journal of Neurosurgery, Spine, during my time at UW, and we found it to be a very safe technique, and no, nerve roots did not have to be sacrificed. And the main thing is that there's a number of little tricky tools, right angle tools to basically facilitate developing a safe plane. I think this is however you do it, whether you did transthoracically like what I was trained initially, or endoscopically, whatever, you need to have a clear plane of the dural sac relative to the healthy vertebral body above and below, ideally from both sides, that crisscross the midline, so you have right of ball probe nerve hooks of different lengths, until you have that very clear plane established, and then you implode that. So that's my main technical pointer. But after that, we've sometimes had this sinus scope for actual decompression, but usually I just use it for verification. And now with the BK ultrasound, so I'm using a product name here, but that's been a game changer. But you do need to have a full laminectomy. You can't do the midline sparing technique. So
she made
yeah, sorry, go ahead.
She made a pretty rapid improvement post-operatively. She was in the hospital for just a couple of days and was mobilizing with physical therapy and occupational therapy with a walker, and she hasn't had any further falls since, and she's reporting improvement and her avoiding difficulties and issues from transitioning from sitting to standing.
Yeah. So 2 quick things before we go to your talk, Dr. Lockey. And one, NASCA. So for thoracic cords, where there's a true cord impairment, this patient had a pretty dramatic cord signal change. I do use the NASCA's 2 protocol preoperatively because, again, the cord is so impaired. This is, again, lower thoracic cord level, but it's true cord level. Is this crazy of me? Or, I mean, I've been in enough thoracic cord cases. I just have the highest respect for the cord fragility, and I try to give them the optimum chances to avoid deterioration from intraoperative trauma. So high MAPS, and if in doubt, give NASCA's 2 protocol steroids before we ever invade the cord area.
I like the NASCA's 2 protocol, and I think Michael Failings does a great, he's had talks with you about on this platform about it, where I think there was too much dogma that came out of this idea of not using high-dose steroids for spinal cord injury patients. And I think in the right patient, it really makes a lot of sense. And for this person, young, physiologically, no pulmonary issues, I would absolutely use NASCA's 2. I think one of the challenges that we've had, not just in my time here, but at other institutions, is that dogma is very pervasive, and it can be hard to get buy-in from your intensivist colleagues and elsewhere to continue with the protocol in the perioperative setting.
And then Dr. Qureshi, regarding that very large patient from prior, asked why not a post-op MRI? And that goes into Dr. Bhargava's also, why not a corpectomy? Again, I would have liked to do a corpectomy. I was very happy that we got this patient off the table, healthy, and without causing a catastrophe. So this, yes, in an ideal world, to both post-operative MRI. We actually got a post-operative MRI, but it was completely useless. We did not have an ultrasound back then. Now I would have used an ultrasound also, but And post-op MRI is just too much artifact ridden, especially in these large patients with hardware in there. So those are all great questions, and I thank you, Dr. Qureshi, for those questions, also and Dr. Bhargava. Image guidance, what do we use for image guidance? Do we, the question again in the chat room, do we use image guidance for screws?
No.
No. No, yes. But my partner, Dr. Skuin, has finally made it. We had a bad storm here, and he got deprived of going around. So those are some of the main thoughts, but did you like the ultrasound? Are you going to use that?
Yeah, I'm definitely adding that to my armamentarium. I think it was very helpful, and I previously hadn't used it before this, but the visualization that you can get with it is actually really nice. You can see the continuity of the cord throughout very nicely.
Yeah, this is definitely a breakthrough technology. These newer ultrasounds are remarkable in their image acquisition. And yes, you do need a little bit of a laminectomy. That's definitely a factor. Please, by the way, for the audience, a self-advertisement here. This Friday evening and all Saturday, we have an all-star group of surgeons talk about spine trauma. It's a 10th annual spine trauma course, and particularly proud of having Dr. Bob McGuire, one of the heroes in our movement and past president of AO, the AO Foundation, even as a spine surgeon, here as a mentor and to acknowledge his great contribution. So please dial in Friday night here, Seattle time, and all day Saturday with great demonstrations, courses. It should be very interactive, should be super interesting. And yes, we'll have ultrasound demonstrations, I think also in terms of cord visualization. So with that self-advertisement, thank you, Dr. Hogshead, and I'll come up front to introduce our speaker. And I want to again acknowledge our listeners from around the world. It's a great privilege and honor to introduce Dr. Stephen Lockey, Assistant Professor of Orthopedic Surgery at the University of Virginia in Charlottesville. He is unusual in that he, at early age, did not just get his MD, but his MBA also from Georgetown. He's had all the academic honors one can hope for and strive for. Member of the Alpha Omega Alpha Medical Honor Society, and he got multiple leadership awards. He did his medical school at Georgetown, his residency there, and was the academic chief. Of course, someone like him would be promoted to that and recognized. He did his fellowship at the University of Maryland, and he referenced some of his mentors there. And in 2023, due to his multiple awards and great early academic promise, he also got the 2023 North American Spine Society Traveling Award. And we're very privileged, together with HSS and the Rothman Institute, to serve as his third teaching institution. And he's left a very positive imprint here, and we've been so thrilled about our interactions with him, and we're very glad and honored that he would give his time to teach us about thoracic myelopathy, and I'll ask him to again introduce. He's out of, so you might have to take off your blur function. His fellow again, because I don't have a bio on him. But
yes, no problem. This is, thanks so much, Dr. Chapman. It's great to see you again. Great to see you, Dr. Skorian, and all your clinical fellows. Miss you all in Seattle. Wonderful to be back. This is Zasheer Akhtar, our fantastic clinical fellow. He's only been with us for a couple months and is already making waves. He's also hot on the interview trail, so somebody better scoop him up fast. I'm going to go ahead and share my screen. Okay. Thanks again. And as Dr. Chapman mentioned, spine surgeon here at the University of Virginia in lovely Charlottesville. We have mountains here. They don't quite rival what you have in the Seattle area, but we certainly love the outdoors here, and it's great to be with you from the East Coast. As I mentioned, I'm joined by our clinical fellow, Zasheer Akhtar. We're going to talk a little bit about thoracic myelopathy, problem near and dear to my heart, something that we saw a lot in training and see a lot in practice here at the University of Virginia, and it's often a missed or underdiagnosed or a delayed diagnosed condition, which can have some catastrophic consequences, as illustrated by some of the case presentations we had before. So to start us out, I'm going to have Zasheer take us through a quick case.
Yeah, so we had a 68-year-old female present to the emergency department, severe acute onset of back pain, as well as inability to ambulate, subjective weakness in her lower extremities, no bowel or bladder issues. On exam, she was noted to be unable to ambulate, hyperreflexia through the lower extremities, preserved motor strength, but diffuse paresthesias on examination. We got complete neural axis imaging, which was positive for some lumbar spondylosis, but her main source of pathology was this T7 pathologic fracture with retropulsion into the canal, and you see some resulting spinal stenosis on the axial image there.
So we'll come back to the case, but just briefly, and it was mentioned earlier, thank you, Nick. So that we did publish this article earlier this year in the Yellow Journal with some of my mentors. So Steve Ludwig, who trained me at the University of Maryland, and then Francis Shen, who's our fearless division chief here at the University of Virginia, both outstanding spine surgeons, great leaders, great mentors, treat a lot of patients with this condition and have taught me a lot about the spine. So a lot of what we'll talk about is highlighted in this article. But when you think about the epidemiology of thoracic stenosis, the original descriptions actually came from overgrowth phenomenon. So acromegaly, Paget's disease, or maybe deformity in the form of Scheuermann's kyphosis. But primary sources of thoracic stenosis is really paucity of data on what the actual epidemiology and prevalence is. So thoracic disc herniations, ossified ligaments, tumor, and infection. When you think about thoracic disc herniations, they most commonly occur in the lower thoracic region towards the thoracolumbar junction. And in terms of disc herniations that we see in the spine, they're very infrequent, and there are biomechanic reasons for that we'll discuss later. But only about 1 to 4% of patients with disc herniations in the spine will be in the thoracic region. Most are asymptomatic, typically men between the 3rd and 5th decades of life, and they occur centrally and paracentrally. And when they do cause compressive pathology, they can result in pretty severe symptoms. Importantly, and this is the take-home point, and we highlighted this in the cases earlier, there's a propensity for calcification. So about 42% of patients with a thoracic disc herniation will have a calcification, and those can be intradural. It's really important to diagnose that in the preoperative setting. So a CT scan has really become an important part of the preoperative workup, as highlighted in the cases that you mentioned, Dr. Chapman. Additionally, it's not surprising that patients with Scheuermann's disease will have a propensity for thoracic disc herniations. That anterior wedging can cause eccentric loading of the disc and cause extruded fragments to cause canal compromise. I love classic articles. So this is the original Batson's article where they looked at the venous plexus around the spine and where they injected contrast into cadavers and then compressed the abdomen. And they were able to map, there's this valveless plexus that bypasses the portal and the pulmonary systems that completely engorges the spinal canal. And this can be a source of seeding either from infection or tumor into the spinal column. Another theory is this end arterial network, whereby the nutrient artery penetrates the dorsal aspect of the vertebral body and then feeds towards the anterior margin of the ALL. This may be why we see discitis osteomyelitis occurring in the anterior column at the initial onset. But pathologic fracture from these conditions or compressive pathology from infiltration of tumor or infection can obviously cause thoracic stenosis and the neurologic sequelae to follow. And then ossification of the posterior longitudinal ligament. This is something that is seen more commonly, obviously, in the Eastern Asian population. They published a lot on this, particularly out of Japan. Seen much more frequently in the cervical spine, but we do see it in the thoracic spine, particularly in the upper thoracic region. And the problem in this region is the degree of kyphosis really moves the cord ventrally and tethers it to the point where if you have any compressive pathology in the anterior margin of the canal, it can result in critical stenosis and neurologic symptoms. It's important to understand that patients with OPLL also have a propensity to have ossification of the ligamentum flavum. So in that CT scan in the diagnosis, you can see circumferential stenosis, and that's really going to dictate our approach to care. I don't recommend memorizing this classification, but we obviously see OPLL more frequently in the cervical spine. But I do think this classification is helpful for determining treatment, and the same applies in the thoracic region. If you have a localized ossification of the posterior longitudinal ligament, for example, in figure A, where maybe it's just behind the vertebral body, you may want to go for a direct decompression, getting control above, below, side, doing a corpectomy, relieving the stenosis in the ventral margin of the cord. Whereas patients, say in C or D, where they have more diffuse disease and getting control safely can be more challenging, doing an indirect decompression, achieving float back may be the safer option in those patients. And then ossification of the ligamentum flavum. We see it more frequently towards the thoracolumbar junction, but I think importantly, centrally based ossification of the ligamentum flavum with pedunculated morphology, where if you look back at the literature and how it was classified and described, it's actually the morphology that can be important, because if you have a central pedunculated ossified ligament, that tends to be more stenotic, causing myelopathy. Those tend to occur higher up in the thoracic spine. And I thought this article was interesting. So this looked at globally, what are the trends and sources of thoracic stenosis? And almost relieved, right? We're spine surgeons. 42% of patients who have thoracic stenosis have a source of ossificational ligamentum flavum. Well, that would be great because you can get control above, below. We're familiar with the posterior-based approach. It's kind of reassuring, but if you look regionally and what we're treating in North America, the vast majority of patients have ventral pathology. So over 95% have thoracic disc disease as a source of their stenosis. And so really our approach to treatment and getting ventral control is going to be different than other regions of the world. And then I thought this was an interesting addition to the article where they looked at the sources of pathology and where they're found in the spine. And again, we see thoracic disc disease, thoracic disc herniations more commonly towards the thoracolumbar junction. And there are biomechanic reasons for that. It tends to mimic the lumbar spine versus ossification of the posterior longitudinal ligament tends to occur towards the cervical thoracic junction. And then I have this other category here of sources of thoracic stenosis. So this is a patient who was sent to me, had a kyphoplasty at 3 separate levels, secondary to compression fractures and ongoing pain. And this is just a word of caution, right? For every action, there can be a reaction. So this patient had this procedure and afterwards had severe back and leg pain, couldn't walk, had dysesthetic leg pain, numbness and tingling. When I saw him in my office, I sent him straight for an MRI and it showed this circumferential stenosis at T10 and 11. And you can see there's cord signal change. And now we have a difficult problem. We have a patient with cement augmentation of mantle in the vertebral bodies around an area of stenosis. So we took him on an urgent basis. And I used K-wires to pass a trajectory either adjacent to or around the cement mantle, and then used a cannulated drill to drill through the cement mantle to get our fixation, and then did a very wide laminectomy. And we were ultimately able to achieve this construct in a patient with severe osteoporosis and this prior cement mantle. And I did get a post-op MRI, which showed a good flow back of the cord and decompression of the canal. But just a word of caution that we have these procedures available to us and they seem innocuous, but there can be significant consequences. And I'm sure you're seeing a lot of these in Seattle as well, where procedures are done elsewhere and then patients show up with some problems. So in reviewing the anatomy, and I think this is important understanding thoracic stenosis, again, the thoracic spine lower down towards the thoracolumbar junction, the moment of inertia closely mimics that of the lumbar spine. So the stress on those segments and those discs mimic that of lumbar spine. We see more disc herniations, more spondylotic disease, the propensity for that spondylotic stenosis versus towards the cervical thoracic junction, we're seeing more commonly OPLL because it mimics OPLL in the cervical spine. These regions separate and therefore the pathologies that we see in them are distinct. It's also important to understand myelopathy and why we develop ischemia to the cord and from compression. And this can inform us on a basis of how urgent we need to take myelopathy, whether it's in the cervical or the thoracic spine, because really they are different entities. The blood supply is different. The stress that the cord can withstand is completely different. So when you have compression of a normal cord and it becomes deformed, the vessels in the cord which penetrate from outside the end become tortuous. The blood supply slows and it can sludge and ultimately clot off. And you get areas of microischemia, which result in a new neurologic baseline for the patient, right? And this study looked at vascular compromise. If you have 3 millimeters of compression laterally, or even just 1 in the A to P dimension, it can result in vascular compromise. And then this study looked at vascular supply to the entire spinal axis, and they looked at 35 different cadavers. And what they found was that the cervical and the lumbar spine ultimately have very variable blood supply, but it's robust. But what was a common feature is that the blood supply to the thoracic spine, particularly between the T4 and the T8 regions, is very tenuous. And so when you combine, this idea of you have a kyphotic region of the spine with a draped cord, restricted motion with the dentate ligaments, a propensity for intradural compression, severe ventral stenosis, with a compromised blood supply, this makes for a very dangerous entity. And it's important for us to understand that both in achieving early diagnosis and careful planning to management. So when we think about that, right, thoracic stenosis, thoracic myelopathy is a spine surgeon's nightmare, right? For those reasons that I mentioned. We're actually very lucky as surgeons and as humans because our bodies have very rigid thoracic segments, making them less susceptible to the types of changes we see in the cervical and the lumbar spine. So we have coronally oriented facets. We have articulation with the rib cage, which has been theorized as this theoretical fourth column. So this is another classic article whereby they resected the posterior elements going all the way to the costovertebral joint. What they found was after they loaded the specimens, the costovertebral joint in the thoracic spine confers tremendous stability, both in flexion and extension and in rotation. So we're fortunate from that standpoint. But when we see these problems, they tend to be very severe. And then how do patients present? Well, classically, right, myelopathy, a stepwise deterioration in neurologic function, which makes sense from the reasons that I mentioned earlier, right? You have a cord that's compressed, the vessels are slow in terms of their blood supply to the center part of the cord. Maybe you have some area of increased stenosis or compression. All of a sudden, a few of the microvessels close off. There's ischemia to the cord, and there's a new neurologic baseline for the patient, resulting in the stepwise deterioration. But in the literature and anecdotally, thoracic myelopaths present differently and they progress differently. That's why the clinical suspicion is so important. And if you look back at the literature, what is the most common presenting finding? It's actually not weakness, it's lower extremity numbness. 50% of patients with thoracic myelopathy will have lower extremity numbness. So that should always trigger your brain, be a red flag. Do I need to image this patient? What additional exam findings do I need to look for to lead me down this road of making a diagnosis? And then what was interesting in this article, if you look on the right-hand side of your screen, they could actually pinpoint the area of stenosis based on the presenting findings for the patient. So for example, patients with T10, T11 compression presented with lower extremity weakness and numbness versus compression at the conus presented with foot drop and hyporeflexia, not hyperreflexia. So that just illustrates this point that you can have reflexes that don't necessarily match up with what we think of central nervous system compression. And that takes me to this key paper, which is that, and I think it was highlighted very well in the cases that you presented, ankylosing and Babinski sign, these pathologic reflexes are only present in about 40% of individuals. And so it's really the constellation of physical exam findings when we think something doesn't make sense, right? Somebody with lumbar stenosis, but they've got proximal weakness. Maybe they've got gait instability, but their hand dexterity is fine. They come in and their shirt is buttoned. These types of things, it's the constellation of findings that really have to lead us down that road to obtaining advanced imaging. And when we think about imaging modalities, I mean, this is pretty straightforward, right? You get an MRI, there's a large central thoracic disc herniation, but to the point that was illustrated in the cases and that I mentioned earlier, we absolutely have to get a CT scan because this image can all of a sudden turn into this image on a CT study where you have a very large calcified component. Getting control of this in a safe manner can be very challenging, and you would not do a traditional sort of laminectomy approach for this. I would err away from doing a transpedicular approach just because I would want to get ventral enough and create a large enough cavity to tamp everything away. This is a very high risk case. And then going back to my previous point where the morphology of the disc can really be important in terms of determining if something is intradural. And if there's any suspicion, some people will advocate for a CT myelogram in the preoperative setting to really understand if there is some intradural component. And then I'm really glad you guys mentioned ultrasound. So I had never seen ultrasound in training, in residency. And then at the University of Maryland, I worked with Charlie Sanser, who was Dr. Skorian's colleague and co-resident when they were residents together at UVA, and Ken Crandall. They were on the neurosurgery side and trained me. And we used ultrasound. And it is amazing the anatomy that you can see with this new technology in ultrasound. So you get these axial and sagittal cuts, you can see the compression, and then after you do your decompression, you can really verify intraoperatively and leave the operating room with greater degree of confidence that you've achieved your surgical goals. And so that's been a really important point for me in practice is utilizing this type of technology. It's low cost, it's safe, it's readily available, and you get these amazing images to confirm your surgical goals. And I think in terms of imaging, it's also really important to mention we're dealing with the thoracic spine. Wrong level of surgery is a concern. And everybody has a different method for determining where they are in the thoracic spine and that they're at the correct level. There is no right method, but this article highlighted some of the options are available to us. You can use adhesive markers on the skin following MRI. Those have a tendency to move, however, and only good for a posterior-based approach. Some people advocate for intralaminar methylene blue, but that can obviously diffuse away from the site of interest and is also not helpful if you're doing a transthoracic approach. And then, vertebroplasty, but that has consequences that we discussed previously. I think the most effective tool for me in training and in practice has been I to place a fiducial and then do a CT scan after the marker's placed to confirm the level. That way in fluoro, you can see the site very clearly, but obviously this is resource dependent and time dependent, and it's not always feasible in patients who are presenting with rapid neurologic decline. So what about surgical management? Well, starting with the most aggressive sort of approach, if you place the patient in the lateral decubitus, and this may require an approach surgeon, but if you go retropleural, you take down the rib, and you access the spinal column. This is a great technique to achieve ventral access, particularly for these large central calcified lesions where you're worried about adhesions and you're worried about getting control above and below. This approach, you basically take down the posterior 2/3 of the vertebral body and disc, you create a cavity, and you get ventral access to the cord. You decompress, and then you look for that outpouching of the dura within your cavity as confirmation that you achieved your decompression, and then you can insert whatever you like, maybe that rib that you took into the void after you've achieved your decompression. Costotransversectomy has been a workhorse for me in treating these patients. It is morbid, however. You have to have enough soft tissue excursion above and below the levels to get out over the rib and then take down the rib. But it is a great way to access the ventral margin of the canal. I found that I can get across the midline, but not all the way across to the contralateral side of the cord by doing this technique. And so for those ventral or, those central or left or right paracentral disc herniations, this is a really good technique for me to get control of the lesion and make sure that I'm not causing any compression on the cord when I'm doing the decompression. And then, the transpedicular approach is sort of classic. The one word of caution for this is that it really limits access and visualization ventrally. And so I think for these soft disc herniation, for me, the key indication is a soft disc herniation in the paracentral location. You take down the pedicle, you make an annulotomy, you use some angled instruments, and you take out the disc herniation. And then you do a wide laminectomy, and you confirm good decompression using an ultrasound. You showed a great case example where you did a transpedicular approach and were able to tamp away the calcified disc fragments. I think that was very well done, and it's nice for the patient to not have done the costotransversectomy, and obviously can be achieved with great success. But if there's any sort of question or concern about adhesions, I think the more ventral you can get and getting wider, taking down the rib, taking down part of the body, doing a little hemicorpectomy to access the disc space is much safer. And then I'm going to have our fellow, Dr. Akhtar, take us through some outcomes and then finish up the case. And we're happy to take any questions.
Thanks, Dr. Lockey. So hopefully this kind of wraps up a lot of the main points that we've mentioned today. So this first article was a case series of 20 patients that were surgically managed for giant thoracic disc herniations. And the big take-home point here is that the outcomes are mixed. About only 53% experienced neurologic improvement. And of note, down at the bottom there, you see that 5% actually experienced neurologic decline. I think when you think about the amount of cervical myelopathy that we treat, a 5% neurologic decline rate is actually very high. Other complications included pleural effusions as well as progressive deformity for these patients. This next review article out of Cleveland Clinic here, the main take-home point was that standard laminectomy alone, they did not feel was an appropriate procedure. They reported a mortality rate as high as 35%. They also reviewed studies and had as high as 60% rate of neurologic deterioration in patients undergoing laminectomy alone. I think this again just points to the anatomic considerations of the thoracic spine, the regional kyphosis, the risk for post-laminectomy kyphosis that will result in continued neurologic compression. And then finally, this paper looking specifically at the posterior longitudinal ligament ossification in patients undergoing surgical management for that, comparing decompression techniques. What they noted was that patients with upper thoracic OPLL tended to do better than patients in the lower thoracic spine, but they did not note any clinically or statistically significant difference. However, there was a trend towards statistical significance with circumferential decompression. And again, instrumentation was beneficial in these patients, again, highlighting the kyphosis and the rigidity in the thoracic spine, as well as the tethering of the cord, and preventing that progressive kyphosis may help, and instrumenting could be beneficial there. So going back to our case, again, 68-year-old female presented to the emergency department, severe back pain, inability to ambulate, hyperreflexia with some long track signs, but otherwise preserved motor strength. imaging again showed this T7 pathologic fracture with retropulsion into the canal. Given her clinical presentation as well as these findings, she was taken to the operating room. She underwent a T7 corpectomy through a right-sided costotransversectomy, as well as T5 to T9 instrumented fusion and cement augmentation due to her osteoporosis and poor bone quality. Here are some fluoroscopic images. We began by doing our pedicle instrumentation and cement augmentation. This is us performing the corpectomy. You see the 6 diamond burr in there. Dr. Lockey's really turned me on to that. I think it's a great tool to get decompression of that anterior body, as well as get some cautery and limit your blood loss in this otherwise large procedure. This is entry of our corpectomy cage and then expansion of the cage. I think using the expandable cage in this setting was really nice in having some restoration of her alignment, and then locked her down into place. Here's some final fluoroscopic images and postoperative x-rays. Postoperatively, the patient had some neurologic recovery, return of her sensation to her lower extremities. She returned to ambulating. So overall, I think we got a positive outcome in this otherwise challenging case. Happy to take any questions.
Beautiful. Yeah. Authoritative and really circumspect in all the regards, diagnosis and management options. 2 questions. Do we have a classification outside of using the Asia categories for thoracic myelopathy severity? Do we have something that's correlated to the MJOA or the Nurek scale, or should we just apply those?
I'm not familiar with one, but it's something worth investigating because, as I mentioned, I think just anecdotally and in the literature, these patients present differently and they progress differently. So I'd have to look into that, Dr. Chapman. Are you aware? I'm not aware of one off the top of my head.
I am not either. I apply the Nurek scale because it kind of makes intuitive sense. It uses just the basic ambulatory skills, but it is way too undifferentiated for the peculiarities of the thoracic cord, which you and your colleague definitely nicely identified. Now, let me involve Dr. Skuyan, another UVA grad in this case, and UVA loyalist. How do we do this with image verification of levels when we don't have bony markers? Like the case that we right now saw is one of those disaster cases. But how do we really get to the levels? Do you still use fiduciary markers? I know you.
I do. I mean, I think, hey, Steve, how's it going? Great
Hey,
presentation.
good. Good to see you.
Yeah, good to see you too. Excellent cases were showed this morning. I think there's kind of 2 options for me. Is one, I think Steve, you talked about it, is getting IR to put a fiducial in. And I think it's really critical to always get a CT or a CT myelogram after the fiducial placement. Jens knows this, but I've seen cases where even the radiologist puts it at the wrong level. And so you go in and actually one of my partners had a case intra-op. They were off by 2 levels on this case. So I think it's important to get a CT after the fiducial's placed. And I think, Steve, you mentioned that. I know you guys do that in Virginia. I know Charlie and Steve do something similar in Maryland. I think image guidance is reasonable. I do think, obviously you can count, but it's easy to get burned. So that's my, I think, go-to. The one thing I wanted to talk about was, OPLO. Specifically, Steve, I think you showed some cases there, and, I learned a lot about thoracic discs and OPLO from Jens. And it's interesting because in the neurosurgical community, we always do laminectomies or decompressions. And I was wondering, Steve, what your thoughts on are, we see a lot of OPLO, especially being in Seattle. What are your thoughts on, do you fuse or do you do decompression? And then I also want Jens to weigh in, because I do think there is a difference in opinion, and I think it's a challenging case of, do you do a fusion or do you do a laminectomy in OPLO?
I prefer adding stability. I think I was always taught that is helpful in preventing progression of the pathology. So in case of OPLL, I'm typically always doing an instrumented fusion with a decompression.
So you always, let's say if you have like 3 levels of OPLO, you'll fuse those levels and then extend it, or do you just fuse those particular levels?
So in the thoracic spine, I think in that particular case, probably go one above and one below, where we're seeing the source of pathology to add that stability above the lesions, above and below the lesion, and then do the decompression.
And then Jens, what are your thoughts on OPLL infusion, or do you do laminectomy?
Over time, from what we understand from OPL, it's an inflammatory disease with a genetic predisposition. And if you don't fuse these patients, they'll definitely continue growing. So laminoplasty, one of my favorite surgeries, was done for OPLL, but now we know that it does induce further growth. So doing anything we can to stop the process is important. By doing 1 or 2 levels above and below an OPL process, we actually do allow the cord to float back, as you say, and I think that's a very important part. So protecting the spinal cord and giving it room to breathe and letting it re-expand above and below the lesion to avoid this kinking of the cord, and reestablishing CSF flow as much as we can is important. To address, and this goes back to Dr. Lockey, to address the issue of dural tears. When we do thoracic decompressions with chronic diseases like OPLL or calcific disc herniations, dural tears or dural erosion can be a fact of life. How do we handle those? This can be very precarious when we go through the pleural tissues and have a pleural meningeal fistula. This can be a real disaster. So how do we handle thoracic dural deficiencies?
I think the key is, repair every tear. You can't always get there in these thoracic cases, right? And I think, and particularly the ones where you leave this void from tamping away a very adherent calcified disc. The key for me is getting that hematoma to form, to help clot it off. And then I use, some of the sealant products. And then what is critically important, I think, is leaving drains, and a sufficient number of drains to help prevent, that collection from forming. And then mobility afterwards, I tend to keep them, I just kind of follow the standard lumbar protocol, keep patients flat, and then slowly get them up the day afterwards.
Great. So I think we're at time. Any final closing comments? I thought this was a authoritative thing. We should do an instructional course lecture or a focus issue with your insights on thoracic myelopathy. I learned a lot. The background information on vasculature of the cord, again, just shows me how complex and daunting this is and how fragile we are. And so many of those patients are really challenging because they have comorbidities that are substantially influencing what we can do. And want to also thank and recognize our many colleagues around the world, especially, as I said earlier, our friends from Pakistan. They'll have a great meeting this weekend, and I'll do double hits. I'll do the Spine Trauma Summit here, but I'll also, in the middle of the night, participate in their Spine Summit. So many thanks for that invitation. I want to recognize the emerging world of endoscopy. Dr. Yanamura and others talked about doing endoscopic decompressions for some of those cases, and I recognize that, I applaud that, and I'm scared of it. This is beyond my means. I'm very happy with my posterior procedures. I don't know what the younger generation thinks, but I'm reasonably happy, but I'm happy to learn and acknowledge that there's expertise out there by others that is still evolving. So I'll stay with that. But great to see you. Thank you for this wonderful education today, and for the partners around the world for their participation. And please join us this weekend for our Spine Trauma Summit.
Great to see you all. Have a great day.
Great job.